Hi, welcome to Fox News. I'm Kimberly Guilfoyle, your host, and we have a very special program for you today. Special guest is joining us here in studio, Dr. Elan Singer. He's also an officer in the Navy, I believe a lieutenant colonel in the Navy Reserve.
Lieutenant Commander.
Commander.
Yeah, that's
in
the Army,
Navy
Kimberly.
Reserve. Oh yes, I'm sorry. I'm an Army girl. I have to say. Well, my father was in the U.S. Army, and my brother went to Army Navy Military Academy though in Carlsbad. So we got a little bit there going together. So we have you here today, and we want to talk about the program that you're involved in, the Iraq Star program. And, right, you're a part of that to do...
I am. That's a small part of what I do. What I mainly do is just Navy Reserve duty in Bethesda, Maryland.
Okay, well, let's start and talk about that. And, of course, we have regulars here with us, Dr. Dale Archer and Dr. Catherine Smirling. And we're going to bring them in, incorporate them into the program once we get a little bit more familiar with what you do, and then we'll talk about that.
Right.
Okay, so start off with the program, what you're involved in, and with the Navy Reserve too.
Okay, so I'm a private practice here in Manhattan. However, I have the privilege of once a month getting in the car, putting on this uniform, and operating on our nation's heroes in Bethesda, Maryland. I've done that for the past, in the Navy Reserve for the past several years. I joined as a resident, and it's just a nice change for me from being in practice here in Manhattan to do my small part in service of our country.
Now, how did you end up, involved in the program? Because obviously you're a surgeon, plastic surgeon, went to medical school, and you went and did your residency here in New York, right?
I did. I trained at Mount Sinai Medical Center, and then an extra year at Lenox Hill. So I did 7 years of surgical training, and then during that time is when I decided to join the Navy. I had a recruiter come to speak to a bunch of residents to tell us about this program where you could be a Navy officer in the healthcare field. You're protected from mobilization while you're completing your residency, and then you serve a couple weekends during the year during your residency. However, when you're completing your residency, it's one weekend a month, and then 2 weeks a year, what you see on the commercials. And
did you think you wanted to be involved in the armed forces and be able to serve? Like, how did you get that into your head?
Both my parents were in the military, and I guess from when I was a child, I just wanted to get involved in the military, and then I had this opportunity as a resident to do it, and here I am.
And so your parents both served in the military. What did they do?
Yeah, my mother actually was in the Israeli Defense Forces, and my father was a Navy dive officer in a submarine.
That's amazing. You must be so proud of them. That's so interesting to have parents that cool.
I am. It was great growing up, listening to stories from both of them. And so I never really had an opportunity to do so because I knew it was going to alter my career path in becoming a surgeon. But then when I had this opportunity as a resident to serve, I jumped on it.
Yeah, well, it seems like a perfect, marriage of the two worlds, both fields that you're interested in, both things that you wanted to serve in.
Right.
So, well, that must be great. So now how long is your commitment then to the Navy? How does that work?
When you first sign on in the Navy as an officer, you can't resign your commission for 8 years. I've completed my 8 years about a year ago, so I can actually resign my commission whenever I want.
But you don't want to.
But I don't want to. No,
right.
I don't want to, and I actually enjoy every month going down to Bethesda. It's just a nice change from what I do here, and it's such a different world. To be able to operate on these fine young men and women, to try to get them back into action, whether it be in the civilian world or back into the military, as many of them want to go back. And it's just it's a great, like you said, it's a great marriage of a civilian, but being able to on the weekends do a small part in the military. And
you just returned from there.
I did. I was there this weekend. I had a reserve duty this weekend.
So when you go there, give us kind of a day in the life of an example of what you do, what you see, and what the experience is like.
Right. So I'm in a reserve unit that is actually the only reserve unit that is a functioning unit in the operating room. So every weekend we do surgery on the weekends, mostly elective surgeries. I do breast reconstruction. We have a urologist doing urologic surgeries that I assist on. But at the same time, I'm also there helping out the active duty forces, the active duty plastic surgeons doing war wound reconstruction. So I'm a filler, an extra pair of hands on the weekends when I'm down there of this machine that is constantly working on our wounded warriors.
What have you seen in terms of your experiences dealing with soldiers, warriors that have, are injured, and just kind of the impact that it has on them? I mean, you try and repair them physically.
Right. I can tell you that it is not a downtrodden place. The Naval Medical Center it's not Disneyland, but we do serious work there. but it's a happy place. People, the spirits are very high. It is not a place for sympathy. People don't want it there. They want positive energy. The sailors and Marines who are there are working to get better. Everybody's working hard. The staff, the doctors, and that's what I love about it. Actually, it is not a place to go and put your head down. It is a fine, high energy place.
And even if when someone is injured, a soldier is injured, you find oftentimes they want to get back to serve or to be able to get
Absolutely,
back
many of
in
them
the
do.
game.
Many of them do. When I was in training, we had, in civilian world, my equivalent of trauma, of severe trauma, is motorcycle accidents. People get very, big injuries with motorcycle accidents due to lack of protection. And when you ask somebody on the motorcycle, what are you gonna do when you get out of the hospital? They would say, I'm gonna get back on the bike. That was the number one answer. I'm getting back on the bike. And it's the same answer when you talk to these young men and women. What are you going to do when you get out? I want to go back to my unit. Many of them do.
Yeah.
And if they can't get back to the unit, the military will do everything they can to find them a job that they can do.
To reassign them to
reassign them
something.
because they want to serve. They want to serve.
Have you seen the need is very great in terms of the different protracted wars and engagements that we have going on? The number of people that are injured have very serious injuries, but yet the survivability rate is much higher given the medical developments and technology.
Right. I mean, largely it's because of the body armor, as you probably know. The body armor is evolving all the time, and where these people who are having devastating injuries now in Vietnam, they would have been killed. And even in Persian Gulf War, they would have been killed. So they are coming back alive, however, with devastating, life-altering injuries, and it is our obligation to see to it that they can come back and be functioning members of society, to back in action, whether it be in the military or into the civilian world.
What are you seeing in terms of if you would kind of do a breakdown and analysis of the types of injuries that you see from returning war veterans?
Right. By and far, the number one injury from trauma is from IED, improvised explosive device. There is penetrating trauma from gunshot wounds, but the number one injury is blast injuries from bombs. And so that's where orthopedics and plastic surgery come into play. I mean, you don't think about plastic surgery in this kind of realm, but believe me, there's a lot of plastic surgery going on in the Naval Hospital in conjunction with orthopedics. So it's a lot of extremity injuries. I mean, there's other head injuries, there's all kinds of stuff, facial injuries, but there's a lot of extremity injuries. And it's my job to, from a functional point of view, and a soft tissue point of view, to make people home from in the form and function sort of way.
Yes, exactly. Because you want, obviously, the prosthetics or whatever will take care of the functionality, but there is a form aspect to it where you want to try and make them whole and complete and make sure that it's something that they can work with and live with.
Right, it's tendons, it's nerves, it's bones, it's much more than just
complex.
skin, and it's far much more than just aesthetics. It is a functional type of recovery.
So for a surgery like that, what goes into that process? You have a meeting where you meet with the other surgeons and you come up with a comprehensive plan, and how long does something like that take? What are the steps?
The injured fly into Andrews Air Force Base. They come on a bus right to the main entrance of the Naval Hospital. They come off the bus, and the treatment starts right from that moment. They typically, with these large open wounds, they go to the operating room for simple stuff, washouts. They have very strange bacteria overseas, and so we got to make sure that these wounds are clean. Before you start a large reconstructive staged approach, you need to make sure the wounds are clean. So it's multiple visits to the operating room with many different specialties. Once you have established a clean wound, then you can go ahead and initiate the reconstructive process, which is many operations typically.
Yeah, I never thought about that aspect of it, doing the washout, honestly, because think about it, you're away somewhere in a different country, there's all kinds of different things that we don't have here, perhaps that people aren't exposed to, and you bring that in, and it could compromise in terms of their wound healing, how the surgery could go if the tissues aren't properly cared for.
You have to make sure you have a good bed, we say in surgery, before you start, this scaled approach to becoming, like you said, a whole again. The garden has to be clean before you plant the flowers.
Yeah, you don't want to sow all the bugs in, and then the bacteria is in there.
Exactly, and then you have to start from scratch. If a wound gets infected after you're in stage 3 of an operation, you have to pull out metal, you have to do all this stuff, and you don't want to do that. So, yes, the first few operations are typically simple operations just to clean out the wounds.
It's amazing. So you'll go in then in terms of what are the steps if somebody's going to get, say, a prosthetic limb or get an arm or a leg, like an attachment, you know, below the knee.
Right.
What happens with that? Like, what aspects do you get in on?
I'm already by that time I'm already done with them. So I'm involved in the acute care,
Okay.
closing the big holes, closing the wounds, getting them back to a functional status. Once that is done, the wounds are healed. Then the prostheticians come in with all those fancy things that you see on TV, and it's getting better all the time.
Yeah, it's great.
That's when the prostheticians come in and the rehab starts. And rehab is just as important as my job.
Yeah.
If you close a wound, but a person's been in bed for 2 months and they have to learn how to walk again, well, a closed wound when you can't walk is not very helpful. So the rehab starts, and that's also typically a long process that is initiated in Bethesda, but then people want to go home, and that's continued on either in the VA system or in the civilian world, that there's continuity of care all the way through until the person is really on their own.
From, you know, in terms of the things that I've done, researching and taking a look at what goes on in the hospitals, it seems that the care is very comprehensive.
It
that
is
they're
very
being
comprehensive.
really well taken care of.
Absolutely. It is a well-oiled machine. I trained in New York, and I've been in the finest medical centers that this country has to offer, and I can tell you that the comprehensive nature of the care in the military is first class. It is first class, bar none.
And you guys are going, I guess you're doing, there's a new project now with the hospital, right? There's an expansion.
The hospital is merging with Walter Reed Army Medical Center. It's going to be the single largest facility in the country, in the military. It's going to be one great, large, comprehensive facility. It's going to combine the resources of Bethesda Naval Hospital and the Walter Reed Army Medical Center into one center. So it's actually going to be physically in Bethesda.
Right.
But the name is going to be Walter Reed National Military Medical Center.
How'd they decide on that?
I don't know, that's
Politics.
above your pay grade.
Politics. Do you think that's going to also improve the quality of care? Because
Absolutely. You're going to have many more specialists involved in one area. So now, when a specialist is in Walter Reed and they have an injured in Bethesda, you have to coordinate the two. It's a little difficult. So now you're going to have everything in one location. So it'll be fantastic. It's going to start. They're already starting, but it'll start in October of this year, and then the merger will be complete by the end of 2011.
yeah, I was looking at a schematic, a drawing of it that had
Right.
kind of what was going to go on. So now, say you go in and you do your procedures, and then somebody gets a prosthetic limb. Then when do they get to speak to the medical professionals that are going to help heal them from the inside out?
Right. If you're talking about my colleague specialties, I can give you a good transition to that. That actually starts in the hospital. It actually starts, and I'm sure they will tell you, in the acute care setting. And it continues well beyond their discharge from the hospital. But it is just as important as the physical trauma is just as important as treating the psychological trauma. Absolutely.
Okay, I'm going to hit the pause button right there. We're going to continue this very interesting discussion right after the commercial break. Stay with us.
You should
All right,
video
welcome back. We're going to continue our discussion, and Dr. Singer was just talking about that this process begins, the healing process from within. When someone is first admitted into the hospital, what happens?
As soon as the doctors and the surgeons hit the patient, so do the psychologists and the psychiatrists. Absolutely, the psychological treatment is just as important, as I said earlier, as the physical treatment. If you fix somebody's wound and you don't fix their brain, well, then you've not done them any service.
Right.
So it starts right from day one.
Okay, so they'll meet with somebody. Will they be assigned also, perhaps even like a caseworker or somebody
absolutely.
like
They have a case manager.
Okay.
They have a social worker. They have, and then if need be, they have a psychiatrist or a psychologist being brought in right from the get-go. But it's a whole team approach. They have group settings as well. I'm sure my colleagues will talk about that right on the floor, right on the acute surgical ward. They'll be separated into treatment areas to talk about what they're going through. They'll bring other sailors and Marines in who've already completed the rehab process right there in the hospital to also talk to them, because they need to hear about what lays down the road when you have a leg amputation or an arm amputation.
Yeah.
So it starts very early.
I love an integrated approach. Okay, Dr. Archer, you want to?
Yeah, I was just going to say, I think this speaks to how far our view of mental health has come, because I used to be in a veterans hospital years ago, and at that time, the psychiatric and the mental health aspect was completely separate from the physical, to the point where if you had a physical injury and you were going through the rehab and recovery of that injury, it was considered that you were somehow weak if at some point you needed a psychiatrist or a psychologist. So they would do everything in their power to not be referred.
Right.
And now, of course, we understand the sooner you get involved in this process, and I think the idea of bringing in the survivors and the recovered individuals is fantastic.
So helpful.
To let them know that, this is
Life goes on.
a process, life goes on, this is the hand you were dealt, now let's maximize what you can do going forward. So I think it's fantastic.
I also think it's fantastic, because everyone who serves in our Army is a war hero. And when they return, they should be treated as war heroes. And we have a fabulous example of someone being treated not only from the inside out, but from the outside in.
Right.
Because when they look at themselves in the mirror, they have got to see a strange reflection. It's not the reflection that they went to war with. Perhaps it has changed and altered the way that they appear. So how do you handle that? Do you have any kind of relationship with the people that you operate on? Do you at all follow them through?
You follow them through up until they leave the hospital.
Right.
Every once in a while, yes, you maintain relationships with a few key people through email or what have you once they get discharged. But most of the time, my relationship ends with them, unfortunately, when they get discharged from the hospital. Yeah.
So after you perform, you do surgery, and then they're kind of passed through the
They're
system.
passed through the system, right, to rehab, to the mental health specialists who can continue on. And they obviously come back and visit in the clinic type setting to make sure that their wounds are healing well and that sort of thing.
Go ahead.
But, and so they are prepared for multiple procedures.
Oh, yes.
Because after plastic surgery, after rehabilitation surgery, reconstructive surgery, not necessarily aesthetic, but reconstructive surgery, there is a tendency for the people that are going through it to experience a major depression.
Sure.
Because they look at themselves when they're finished and they expected a miracle, but they don't have that miracle.
Correct. Absolutely. But that's why it's important to keep them in the system. They come back even to see me in the clinic type setting
That's
a year
great.
later to make sure that from a functional point of view, everything is maximized. And if not, we'll take them back to the operating room a year later and we'll do more surgery.
What do you say to your patients when you have someone that's just been so traumatized and you're going to try and help rebuild them, essentially? What kind of, I guess, words of encouragement, or what do you say to them to try and make them feel better about the whole process?
Right. That's a tough one, Kimberly. That is something you don't learn in medical school.
Right.
That is just something you learn how to do as you become a more senior surgeon. Every doctor has to develop their own way of talking to patients about traumatic, devastating injuries. And it's not easy, and there's no script for it. And you kind of do the best way you can to not to lie to people. You don't want to give them a false sense of hope. You have to be realistic with people. And when my father was training in medicine, that's what you did. You always say, well, you're probably gonna get better, or the cancer is not that bad. You're gonna and we don't really do that anymore. We're actually very straightforward with patients. You have to know early on what you're in store, because
Right.
what's in store for you, because the last thing you need to, someone needs to hear in a hospital bed is that they're going to get better, that their arm is going to work when you know
Right.
it's not going to happen, and then a year later you do a delayed amputation of the arm because you can't save it. That is devastating. And so there is no easy answer, but we do it.
Yeah, that must be such an incredible, difficult aspect to it, because you want to be encouraging, but at the same time, if you're not really direct with them and just very honest and straightforward, you can do more damage than good long term.
And you have to, that's what I was saying about realistic expectations and the knowledge that you're going to have multiple procedures, that it is a process, like you said before, that it is a process, and at each point in the process, things will get better, but they aren't going to be instantaneous.
It's not going to be instantaneous.
It's not going to be...
Right. And yet we have to do our best to relay to the patients that it's not one person. It is a large, comprehensive.
Right.
It's really the entire nation that is doing everything in its power to get them back into action, to get them back on their feet.
Yeah, it's interesting. They've actually done studies with relationships to medical problems or surgical intervention relating to the individual's state of mind in terms of how well they do. And they've found that you have psychologically, you have victims and survivors, and the victims are passive. They look in the past and they're pessimistic, and they are always asking, who's going to help me?
Right.
And the survivors are optimistic, active, and look to the future and are always asking, what can I do to help myself? And I think that with those criteria, we know now that when you're working with these people starting off, that instilling in them the proper mindset can make all the difference between a successful surgery or cancer treatment or heart treatment going forward.
Right.
I think we have a, Kevin, do you have this ready? Jennifer Griffin?
Yes.
Okay, can you go ahead and run that for me?
More than 1 million American soldiers have fought in Iraq and Afghanistan since 2001. But once some of these soldiers get off the battlefield, the enemy, it turns out, is in their heads.
Post-traumatic stress and traumatic brain injury are the defining injuries of today's wars.
Now the Army has launched a $117 million project to train 1,500 sergeants to teach troops how to prevent depression, suicide, and post-traumatic stress disorder, or PTSD, which plagues 20% of those returning from combat.
58% of the cases of PTSD come from soldiers who are in the bottom 15% of mental and physical fitness. So the logic is that if we can raise the level of mental and physical fitness, we can prevent PTSD.
Dr. Seligman designed seminars to teach soldiers to avoid having catastrophic thoughts. It is the same model he developed for middle school children. Army generals referred to him as Dr. Happy.
We teach people to calibrate their most catastrophic thinking and to mitigate it with realistic thinking.
Fort Hood, Texas is among those participating in the mental fitness program. Retired Major General Bob Scales pushed the Army to create a soldier as psychologically strong as any of its weapons. But some ask, is it too touchy-feely to be taught in basic training?
This is not about touchy-feely. This is about inoculating our young men and women to the stresses of combat.
And making the soldiers as mentally fit as they are physically fit when they leave basic training. At the Pentagon, Jennifer Griffin, Fox News.
We're back here at StrategyRoom. My producer.
But Jordan is.
Words for our guests.
We need
to try and get in on
and
the
Kimberly for
uniform.
him to get a date
Jordan
now.
for Halloween. Oh my gosh. So we have some pictures. Jordan, we have that Dr. Singer provided us with. Does Kevin have those fed in, the photos that he brought? Okay, then you also have the ones from Haiti, right?
Yes.
Okay. I want to do a segue here for a minute and talk about your time in Haiti. Tell us about that, because we've been covering and have updates about Haiti, what's going on there. I just did one this week too.
Sure. I was lucky. I got pulled in to go with a group from Duke. Actually, I did not go with the Navy to Haiti. I went with Duke University Medical Center. A friend of mine from medical school organized this trip of doctors and surgeons. So about 2.5 weeks after the earthquake, we went to Port-au-Prince. We flew into Port-au-Prince with about 15 people, 5 doctors and surgeons, with a lot of equipment, a lot of different specialties. We landed in Port-au-Prince, and then we promptly drove 2 hours north to a small town with a hospital that had overflow of earthquake victims. And I was there for about 5 days, doing similar type injuries that we deal with in Bethesda. Open wounds from blunt trauma. And so in my specialty, we always want to know the mechanism of injury. So you ask the patient.
These are your photos here.
Yeah, that's actually a photo from the church. They had a church at this compound that was transitioned into a surgical ward because they had so many patients. So that's the church on the compound with a choir, and that's me outside.